I'm just gonna, can anyone see my presentation though with this mode?
No, we can't. So I can share my screen. I have your presentation up if that's
Okay.
better.
Sure.
Perfect. Sorry about that, Dr. Counts.
That's okay. These are not my strengths, these skills. Oh, perfect. Great. Now I can see it. So do I just have to tell you to move, to advance it, or?
That would be great.
Okay. All right. Should we go ahead and get started then?
Sure. The floor is yours. Thank you so much
for
joining today. We really appreciate it. We're so excited.
No problem. I've been excited to give this talk. Talia, Aaron, and I have been working on it quite a bit, and I appreciate the opportunity to be here. I will make a disclaimer, kind of like we sometimes see on kids' toys, that this is a sort of a new topic, and I'm not going to be able to give solid answers for everything, but I'm going to do my best to use what I've found out. You can go ahead and advance that for me. All right, so I wanted to start with a few media updates just with PrEP, because I think PrEP kind of goes into Doxy PeP discussions. I guess I will preface that I am a family physician. I don't know most folks out there. I did my training at UVA. I'm a native of Virginia, but I'm based in the Midwest in Madison, Wisconsin now, just to give you a little background there. But yeah, thanks. But this is one of those rare topics that I literally have some references that are under 1 month old. So that's kind of fun. This may never happen to me quite this way again. But so as you know, the PrEP recommendation came out as a recommendation recently. Should make us feel good about what we're doing. And again, I think a lot of the PrEP and Doxy PeP visits have crossover, but of course not with every single patient. We'll talk about that if you want to advance. And, I looked at this statistic of this was based in 2021. So of the 1.2 million people in the US who could benefit from PrEP, and again, some of these patient populations we can extrapolate to Doxy PeP, only about 30% of them were prescribed PrEP in 2021. Again, this is based on prescription recall. So not all these patients, as you know, fill it, take it, follow up, and do all of the things. So I did the math. So 30% is about 360,000 individuals. So certainly if we can do a better job with PrEP, Doxy PeP is even that much more relevant. All right, you can go ahead. And this is a breakdown of kind of some STI data from 2021. And, some of you have sent me messages in Slack, and I appreciate it. And the questions are, concerns about antibiotic overuse and whatnot. And I even was in my research is prescribing PrEP a problem? Are people using less safer sex since PrEP came out? So if you look at the numbers, let's say of those 360,000 people, let's just play the devil's advocate. None of them use protection. They all got maybe 3 STIs. That's about 1 million STIs if you wanted to blame all this on PrEP, which I am not. But the numbers are nowhere near anything to do really with that directly. And so that's a question that we can certainly say is not directly correlated. I did read 1 or 2 comments. Is that a possibility? And these are just the high number of STIs that were documented in 2021, let alone the ones that were treated and maybe the person didn't go in for testing. We all know that chlamydia is the most common STI. We can impact a lot of these with Doxy PeP, as we'll talk about. And so I wanted to throw out these numbers at the start. Number 2, I wanted to throw out that number not to downplay the incidence of congenital syphilis. It kind of reminds me when Zika was a big deal in the cases of congenital Zika, and just how significant and devastating these infections can be. And remembering that reducing STIs in whatever way we decide, whether it's Doxy PeP or other ways or multiple ways, we can potentially reduce cases of congenital syphilis. And the other point that is all over the literature is that syphilis is on the rise since 2020, and in correlation as well as cases of congenital syphilis, which is a very upsetting statistic for sure. Okay, next slide. I thought this was interesting. This breaks down by state the general prescribing rates for PrEP. I looked in, at the time I had 13 licenses. I just got California, yay. So now I have 14. And I thought, I wonder which of my states, right? I wonder which of my states would have the highest and the lowest. And I would never have guessed either. So my lowest state ended up being Michigan. My highest state, probably not surprisingly because it's smaller, was Vermont. So it's just kind of interesting. The next slide, I'll get into this in more detail. It just makes me even more mindful of when I see a state, maybe is it relevant at all to, focus on or try to get them back for that annual wellness, try to maybe think about, are they PrEP candidates? Even loosely bringing it up, if it's relevant, can be helpful. Okay, next slide. And this breaks it down a little bit more. This is called the AHEAD, the America's HIV Epidemic Analysis Dashboard. And these are the line states, or the states with the higher incidence counties throughout the country, the most populated. So for me in southern Wisconsin, that would be Cook County and Chicago. But you can kind of look and see the more rural areas sort of aren't considered higher priority there. They're in white. And then the highest priority states in kind of that mustard color, it doesn't matter the county. I happen to not have any licenses there, though I am debating now out in Kentucky. But those are states, if you have licenses in, those are considered a priority for helping to end the HIV epidemic, those entire states. So I thought this was an interesting thing to look at, to kind of extrapolate, potentially with Doxy PeP discussions. Okay, next slide. Okay. Sorry. So in 2018, the CDC looked at new diagnosis data for new HIV diagnoses. I'm just touching on this. Again, you all know this. Of these 5 subset groups, 3 of the 5 are relevant for Doxy PeP. So, and we'll talk about this. So anyone who asks for PrEP, technically, essentially, can basically get PrEP. That is not the case for Doxy PeP, which is good, which is a good thing, because we wouldn't give antibiotics for anyone just coming in and asking for anything really. So it just goes to that. So I just wanted to break that down and say that 3 of those 5 we'll talk about for Doxy PeP. Okay, next slide. I didn't want to leave out this comment about transgender population. I actually, in part, chose Madison for my residency. They've been doing trans healthcare here for decades, and so I was doing transgender healthcare for basically 25 years here at UW-Madison. So this is a population near and dear to my heart. They may not be the #1 affected population, but if you look at transgender women, which we have the ability to impact with Doxy PeP, this group is the highest rate for new HIV diagnoses in the US by gender. That is a fact I hadn't really considered. And there are factors with really any medication intervention in this population, some factors within maybe how they've been treated in the past at visits, concern about their HRT, drug interactions there. That I just really wanted to mention. Unfortunately, transgender women are included in the Doxy PeP population that we'll get into. All right, this is out of the CDC out of 2021. It is a little hard for me to stomach a little bit of this. I've talked about this with Talia. Just because some of the questions seems a little antiquated, and I thought I end up doing a lot of sexual histories with my weight management patients, as I'm sure a lot of you do, to try to figure out, do they have a contraceptive risk? How do we advise them appropriately with GLP-1 agonists in particular, right? So I end up just doing a lot of sexual histories there. So I had a patient the other day, I thought I would use it as an example, because the patient and her partner, neither of them would have qualified on this protocol. And so the patient was a cisgender female, and she is sexually active with a non-binary partner. I tend to ask a question, and my sexual history questions are always evolving, but I often say, do you need contraception based on the genders of your partner? or partners. That way, if they don't really meet a gender definition for the non-binary partner, they'll answer. So she answered no, and then specified that her partner was, as she put it, AFOB. And the first thing I thought about was key fob. I'm dating myself. I don't talk and text very well, but that's assigned female at birth, which probably most of you know, but I didn't pick up on that till after the visit. So basically, according to PrEP, which goes by assigned gender at birth, it is women assigned birth having sex with women. They're not included in this protocol, which I wanted to point out. Non-binary patient isn't even included based on the first blue rectangle. And again, this is out of 2021. So again, we have to find out how patients qualify with or without the benefit of this diagram for both PrEP and for Doxy PeP. And I find that if patients don't qualify based on their assigned gender at birth, they've changed their gender either hormonally, surgically, or both, I just say, these are the guidelines for PrEP or Doxy PeP. It's based on assigned gender at birth. And sometimes I frankly, say, I'm sorry, that's just how the rules are. And the patient the other day was like, I totally understand. But I acknowledged that, and I think that was helpful. Okay, next slide. Okay, I did have it looks like it didn't come across. I might have sent this to you after the fact. Hopefully this is the talk that Jess has. I'm a little worried this might be one of the earlier talks. Hopefully, I had outlined this is also from 2021 with the CDC, and there's a couple points in here that I wanted to point out. For follow-up every 3 to 6 months, they changed. There's been contention about this. I saw a letter to the editor, I think in JAMA a couple months ago, recently, being angry about the addition of HIV viral load because of the cost. So I thought I would point that out. That's actually in the CDC guideline. I'm just really the messenger here. I'm not stating we should do this expensive of a lab regularly, but it is in the guideline. The other thing that is in the guideline that I did have sort of highlighted was the importance of 3-site testing discussion. And basically, kind of the way Tali and I've talked about it is, 3-site testing is something we talk about with anyone who's sexually active with any partner with STI testing. Certainly, as we get to Doxy PeP in a minute here, the importance of 3-site testing is that much more important, because if we miss a location and we may be partially treating an infection, that may be a problem either way, but it's in the guideline now. So if patients are resistant, I think it's worth knowing that. Okay, next slide. And then I thought this was an interesting, and I think Talia may have entered this in one of the PlushCare protocols, actually, right after I showed it to her. I didn't know this statistic, but I suppose it's not surprising. We all know about asymptomatic STIs, and I use this statistic. I can't say it has convinced more people to do at-home testing yet, more likely, but I'm working on it. So 1 in 8 patients, men who have sex with men, have an STI in the throat or rectum. So, that's pretty significant. And 1/3 have not been screened in the last 12 months. And we do know, for example, the cefixime that we use, right, is effective for gonorrhea, but not in the pharynx. So we may be covering the rectum, but if we don't know it's in the pharynx and we think we're treating them, we potentially, we really aren't if it's present there. So I just thought that was an interesting statistic, and basically MMWR, I think, is pretty much all about statistics. Okay, next slide. This also, when I thought about it, I found this to be helpful, and I wanted to share this. I found it surprising, but then not. So rectal chlamydia is as common in cisgender women as it is in men who have sex with men, even in those who don't report receptive anal intercourse. I think it's, it goes to getting to basically the normalcy of offering 3-site testing, the normalcy of saying we need to think about this for everybody. It made me think of how we do group E strep swabs late in pregnancy, how we would, swab the vagina and then swab the perianal area because it basically is so close and can grow there. So it didn't really surprise me. On the other hand, I bet if you kind of polled the average person, they would probably think this would not be true. So I think it's something to know about. This is a terrific article, by the way, in AFP from May of 2022. They go over a lot of the CDC STI guideline changes, and those of us like myself have been in practice a long time. We had to relearn that some of these things did change. And one of the authors was out of our residency in Madison, actually, so that was cool. But it's an outstanding article. So I took it out of that article. Okay, next slide. Okay, so CDC has considerations, as many of you know, for Doxy PeP. They don't have, quote, recommendations, so it remains off-label. So that's kind of my disclaimer, like you see on the plastic bags that toys come in or whatnot. That's my disclaimer. But so we'll see what the CDC does with this. But at this time, that's the status, and if patients ask you, that's the scoop there. Okay, next slide. Okay, so Doxy PeP, again, I just talked to a gentleman this morning. He was getting confused with PrEP versus PeP. So we talked about how PrEP is you take it daily, and then PeP is post-exposure, but having to meet the criteria, and he practices extremely safe sex. So he has Doxy PeP, but he's never had to use it. So we had a lengthy discussion about that when I gave it to him. For those of you who treat a lot of Lyme disease or in deer tick states, interestingly, the dose and the timing of Doxy I find interesting is an aside, the same for a deer tick within 72 hours, same dose of doxycycline. I just had to throw in that trivia. You take same thing, take with a glass of water, causes that GERD. If you definitely don't want to swallow it on an empty stomach and lie flat. You will have terrible heartburn. You will get nauseous and probably throw it up. The other thing is with Doxy, we'll talk a little bit more about dosing in a little bit later, but reduction of gonorrhea, including, and this is in bold because of the what I talked about, the asymptomatic cases, the fact that the oral agents don't target and treat pharyngeal gonorrhea by 55 to 67%. Some articles are as high as 80%. And reduction of both chlamydia and syphilis by 67 to 80%, depending on the study. So remember the 2 million plus per year, that was just in the US. I think worldwide per day, it's like 20 million. It's STI statistics are staggering. But anyway, next slide. Okay. Oh, good. It does have these. So again, these are from recent, I thought I would pull some of these Doxy PeP studies. I think I have 3 or 4 of them. I don't like to belabor, but I think it's helpful to know where we got a lot of this from. So this was the Doxy PeP study. It was presented, I think, internationally in 2022. They took men who have sex with men, transgender women, patients on PrEP, patients living with HIV in San Francisco and Seattle. Again, of course, in a study, you're going to have high adherence, right? Because they're going to bug you and remind you. But you can't fake minimal adverse reactions in the study. It was generally well tolerated. And so these were the general results in the PrEP and people living with HIV data on Doxy PeP. The only one that didn't reach statistical significance is labeled there. The numbers are pretty darn similar and almost identical for gonorrhea. Remember, as you know, chlamydia is our #1 STI. Those statistics, 88%, pretty great. So there was that data, and that's kind of the cities and where that came from. All right, next slide. Okay, this I found really interesting. And for those of you concerned with antibiotic resistance, as I think we all should be, I think you will also find this one study particularly interesting. So it has all those letters there. It's a study out of France. It was presented this year. Interestingly, in France, for whatever reason, they have a little bit higher resistance rates that they see with STIs with antibiotics. So I think perhaps that is why, in part, they studied an arm with vaccination and an arm with Doxy PeP. But we'll get to that in a minute. If we just looked at Doxy PeP versus standard arm, that was the first thing that they monitored. So standard arm is just normal STI counseling and whatnot. They monitored them in France, men who have sex with men in this particular study over 9 months. And the success rate was presenting with your first STI. I think it was a length of time from the first STI. And you can see even MGen was included in a reduction in this study. The rates of gonorrhea were similar to the other one, give or take 50%. The numbers were similar to the first study, frankly. Okay, next slide. Okay, so they had an arm also, and again, I think I was looking at the article in more detail earlier this week, a little bit more resistance. So they said, well, why don't we do an arm which compared Doxy PeP and an arm of patients not on Doxy PeP, and we just give them meningitis group B vaccine. And I thought, well, why in the world are they studying meningitis group B vaccine? And if you remember, and I looked this up, it is a strain of meningitis that's in the same classification, Neisseria, as gonorrhea. Again, I just didn't occur to me. So they share 80 to 90% of their genome. So this is pretty cool. So they looked independently at the rates of Doxy PeP versus just a vaccine arm, and in France over that 9 months. And then it was a 51% reduction in gonorrhea. Now, I cannot say if you're advertising meningitis group B vaccine for a teenager to a parent that telling them it's going to reduce their child's chance of getting gonorrhea in college is going to get you a higher success rate. But just knowing if someone has a doxycycline allergy or they don't want to take Doxy PeP and they're in the age range, which is 10 to 25, they can go to Walgreens or wherever and get the Bexsero, which is a 2-part series for meningitis group B, 1 month apart. Now, they did just release, FDA just approved a combination meningitis vaccine. So this will remain to be seen what happens here. But I think it basically is trying to combine your Menveo, your other strains with group B all in one vaccine. But it just got approval. I don't know if that's been rolled out yet. But if it indeed does, then that will make this even easier with less doses, because that is a vaccine given at 2 different ages in a different fashion. Okay, next slide. Okay, so they looked at, this was a publication of Lancet ID. I just tried to find whatever I could to share with you. This is from July of 2022. This was interesting. So it looked retrospectively just at state vaccine registries for this age group over, no sexual history involved, and then looking at incidence in those patients of STIs, which are reportable to public health. And it was that age range 16 to 23. This was done in New York City and Philly. So the first study I showed you was out west. This was out east. And this was done over quite some time. And they saw just with the vaccine, so with 2 doses, a 40% reduction in gonorrhea with complete vaccine series. And even just with 1 dose, it's pretty close, almost 30%. So 26% reduction in gonorrhea with partial vaccine series. So I think we can state that this is the other data I presented was in France, and this is out of the US quite a long period of time. The study in France was only 9 months. Okay, next slide. Okay, this is the article that is not so good, but has, I guess, pros and cons to it. I never like to see a study where a population does not show effectiveness to a very good intervention, but this is the deal right now. The DPEP trial was presented earlier this year. They looked at cisgender women in Kenya on PrEP and unfortunately saw no statistically significant difference in STI reduction on Doxy PeP. And patients do ask me, so I can reference that study was presented earlier this year. I don't really have to give any more detail than that, at least at this time, not showing a statistically significant difference for cisgender women. Okay, next slide. Okay, this was published. This is one of my references from earlier this year. I think one of my other references was less than a month old, but that's all in 2023, most of them. And this shows, I wanted to just have you basically look at the bar graphs. So looking at, I think it looked about 500 participants. They did make a comment that only about 5% of the population was transgender. Most of the population was men who have sex with men. So they did make the caveat that extrapolating it to transgender women is just that extrapolation, that the number N was fairly small, but they were still partly included. So this looks at quarterly visits with, let me see, greater than or equal to 1 STI. So you can see the Doxy PeP is in the blue, and then the standard care for on the left is PrEP, then patients living with HIV is on the right, and fairly similar reduction in STIs as shown in the other papers that I showed you. This is from the New England Journal in April of this year. Okay, next slide. And this, a lot of concern about resistance. All articles give you the caveat, kind of like I gave you at the beginning of the talk. More needs to be done. We're concerned about resistance. We know it's there, it's real. These were the data with tetracycline resistance in gonorrhea in the PrEP patients versus the patients living with HIV. They also are looking at doxycycline resistance to MRSA, because remember, both meningitis organisms and MRSA are harbored in the nares, potentially in the throat. I guess that they've said up to 10% of people can harbor, kind of scarily, meningitis in their nasopharynx and be asymptomatic. It just never crosses their CNS. So they are looking at that, which, we all use doxycycline quite a bit if we're concerned about MRSA, and that is a huge concern. So just know that they are studying that. The differences in this study were not tremendous, but again, statements were made about that. Okay, next slide. Okay, so who do we offer Doxy PeP to? I kind of implied this earlier, but men who have sex with men, transgender women, again, this transgender women, a little bit of an extrapolation, but transgender population tends to have lower numbers in studies in general, with at least one bacterial STI in the past 12 months. With, if we're going to prescribe Doxy PeP with negative initial PrEP labs, again, I would highly recommend doing the 3-site testing if the patient's willing to do it. Particularly high risk would be syphilis infection in the last year, a sexual partner diagnosed with an STI. Of course, we all know many people have no idea on that stat, so we just have to use our best judgment. It may be the number of partners that we consider the high-risk behavior, and that's what we go by, as well as the population. So cisgender women are not included there. Again, we need to qualify who is, and this is based on assigned gender at birth. So you could have a trans man that may not tell you that they are on testosterone, and they have they are assigned female at birth, and you could erroneously give them Doxy PeP. I'm not saying that anyone would, but we could. And so we do need to investigate for both Doxy PeP and for PrEP. So the maximum quantity, this is kind of what patients have told me their HIV doctors have done as well. This is the absolute max. So you take 2 capsules every 3 days, you do the math, and if you did that literally every 3 days, you would need 60 capsules over 90 days. You want to tell patients not to overdose it and think they have to do it daily. So you can generally do that guideline there. And this was out of Joe. This is my reference, less than a month old. This was out of JAMA just a few weeks ago. Okay, next slide. Okay, so again, uncertainty remains about efficacy in certain populations. That includes cisgender women. Again, that's the one study I have, because this is new, relatively new. Some people have messaged me in Slack, certainly concern about teratogenicity, concern about using it in pregnant women or nursing patients who are nursing. I mean, there's always short-term exceptions, pump dump, that kind of thing for maybe a deer tick or short-term Lyme disease treatment, but in general, it's not a population that we are going to deal with Doxy PeP. So in this particular topic, it is not relevant, but I just wanted to make that comment. And JAMA recognized and made a comment about that as well. Okay, next slide. Okay. Either form of Doxy is equally effective. I recently learned from a teenager, actually, for a refill of acne, that he was having trouble swallowing the capsules. So I started investigating, is the Accolade or monohydrate capsule different in size? And essentially they are not. So then I talked to the pharmacist, and it comes in a tablet form, which some of you may know. I did not know that. And it is quite small. He ran it through his insurance, and it was the same $4 copay. I happened to talk to the patient in follow-up maybe 2 weeks ago. I happened to see his mother yesterday for some other reason, and she said he's doing really well swallowing the tablets. And I told her I was going to share this pearl with my colleagues in a talk about how we can get doxycycline more readily in for people that can't swallow capsules. So she was very pleased with that. But I thought I would share that. Okay, next slide. Okay, so I talked about this with Talia. So what code do we use? First of all, and I think she shared with you the new PrEP code. I think it came out last month. I have it written down because I don't quite have it memorized yet, but that's the PrEP code. We kind of put our heads together and thought we could use Z20.2 potentially for Doxy PeP, though if you're going to give Doxy PeP as part of a PrEP code, I suppose you wouldn't really have to use a secondary code. But if it's just for a Doxy PeP consult, that was kind of our thought. Should we prescribe on demand like the patient makes appointment within 72 hours? I've done that. Yes, I've done that, and you certainly can. The issue is, would you prescribe it more than once? Will they go in for STI testing? That kind of thing. I think the 1 or 2 times I've done it, their STI tests were within the last 3 months. So I think you'd have to use your best judgment there. You have to look at the pros and cons of treating versus not treating, making sure they're in the appropriate patient population, right? If they've never had any STI testing, that would concern me. But again, right, we use Cefixime and Doxy for urethritis without potentially having we tell them to go get leave a sample for gonorrhea and chlamydia, but we don't have that in advance. But we don't give them a ton of Cefixime and Doxy. So maybe looking at it that way might make the most sense. Okay, next slide. So these, I thought, just knowing these percents, these were lower than I thought. I don't know if any of you have taken Doxy, but if you've ever forgotten to eat enough with it, you really can get kind of queasy and sweaty. But patients are generally told to take it with food. I would have thought the GI side effects would be higher. I would have thought the photosensitivity would be higher. This was published in that recent article in JAMA that was less than a month old. It lists some other side effects. I wouldn't typically use Doxy if somebody, for any reason, if someone had like esophageal dysmotility. Typically you could see that like in an older person or someone with like dysmotility from prolonged diabetes or something like that. So if they have controlled GERD, I don't really have an issue, but if they've got pretty bad dysmotility, I might have some caution there. Okay, next slide. All right, this is a counseling I probably do every other day. This is sort of a pet peeve of mine that patients don't always know, but I tell them. So did their doxycycline not work for their sinus infection because they didn't tell us they were on Tums and taking 7,000 vitamins? The answer is probably, and maybe it didn't work, but basically if they're on any antacids, if they're on any supplements, and when do patients like slam these? When they're sick. So they may not have been on Zicam or zinc before, now they're on zinc. They may have been told doxycycline is going to upset their stomach, so they think getting Tums is a good idea, super bad. So basically all those things block absorption. So whenever I prescribe doxycycline for anything, I ask them these questions. And again, Pepto-Bismol, that's going to help me keep my doxycycline down. It might, but it'll block it from absorbing. Iron as well. And I would say, boy, no one tells you all of these supplements that they take. And so I try, when I see patients and I find that out, I try to just put it on the list. I just put, dose unknown or whatever, just to bang it on there. So if you see them down the road, you can see these things on there. Now, technically, you can take those things either 2 hours before or 3 hours after, but when are you going to take your supplement? I think that's sort of ridiculous. You'd have to wake up and take your iron with food at 2 a.m. or something. So I just tell people this is the one time when you're ill, if you take it for sinusitis, that I tell you to stop your vitamins because we want the antibiotic to work. And this is a one-time dose for Doxy PeP. We don't want any absorption going down because we want the statistics that I presented to you and the success rate. So in terms of Doxy PeP, and the importance of that versus the 10 days of sinusitis, where maybe they only took Tums twice during the 10 days. We have some forgiveness there, but we really don't with the 2 pills of Doxy PeP all at once. So I really wanted to put that on there. It's just right off of GoodRx. But okay, next slide. I don't know if I have any more, but let's see. Okay, so concern for resistance, we all should have concern. The statement basically about MRSA is it's unclear. I think we all were concerned when we started doing the same dosing for deer tick within 72 hours. Is it going to stop working for Lyme disease? And we've been doing that dosing. Someone can probably tell me. I don't remember how many years that's been approved, but it's been a while. And we still use doxycycline for Lyme disease. So, but they're keeping an eye on it. Remains unclear. Tetracycline-resistant gonococcal strains. I mean, that varies. You saw the graph in that JAMA article was fairly similar with the two populations in that one study, but again, it's all recent data. They're not seeing tetracycline class resistance convincingly in chlamydia, which is good. We've used doxycycline for chlamydia forever, so that's good. And again, this gets at the oropharyngeal Neisseria species. They're looking at that. Of course, the crossover is relevant because the benefit of vaccination. Again, technically, we could do PrEP if someone qualifies. We could do Doxy PeP if someone qualifies. And if they are within the age, we could get them Bexsero. Then we would be superstars potentially. They are looking at gut microbiome with any antibiotic intervention. You all know that. So they're monitoring C. diff. I don't remember the last time I saw C. diff following use of doxycycline, but I'm sure it happens. And then they're looking at that one study. I can't remember if that was out of France. The one study that showed with Doxy PeP reduction in MGen, but there was just that one study. But they're looking at, is Doxy PeP causing any potential resistance there, because remember, doxycycline is one of the 1-2 punch meds we use for MGen. It's not the solo therapy though. So then to those concerned, I talked to a colleague I trained with the other day. I had lunch with her. We were talking about Doxy PeP, and she said, I'm never going to use Doxy PeP. I'm so concerned about antibiotics, and then we started talking about it, and she goes, oh wow, I didn't know all this. I think she's going to use it now. But I said, well, let's flip the coin. Let's think of those bazillion people I showed you, millions of people in the US per year, right? That all those STIs. Iamrocefin reduction that we're not going to need either for treating chlamydia or for preventing gonococcal in the throat, where we could have just used solo dose of cefixime. We don't have to send them in for iamrocefin, or they never got gonorrhea at all. So they never got ceftriaxone. And I didn't take statistics on purpose, but that has an exponential benefit. You treat one person, exponentially benefits the partners, right? And then, of course, less IM penicillin for less syphilis. We need to use iamrocefin and IM penicillin, less so IM penicillin, but iamrocefin for other things, IV rocefin, pneumonia, all these other things. So less things that we have to use it for, the better. And again, these were statements recently, less than a month ago, right out of JAMA. I don't know if you all saw that article. It's a really good article. Okay, I don't think I have any more slides, but can open it up to questions. I don't hear anyone, but people's microphone is probably muted.
Dr. Counts, I see that in the chat, Dr. Town asks what a good treatment for oral GC is.
Right. So if you look at the CDC STI app, which I have on my phone, and I sometimes reference for these more unusual things, like I looked at it yesterday for epididymitis. So epididymitis and the pharynx go similarly. So if you're concerned about urethritis going up into the epididymis, or you're concerned about gonorrhea being in the throat, and you look at the CDC recommendations, question alternative regimen, which it will say cefixime for the other locations. There is no alternative for either epididymitis, which I told the patient, he didn't really want to believe me, or for oral pharyngeal gonorrhea. So you have to treat them with Rocephin for both of those cases. Now, again, with the video exam, you're never quite sure if it's in the epididymis or if it's in the urethra. So you still could use cefixime there, which he kind of talked me into doing. But I had to send a gentleman in for concern about, that's the benefit of 3-site testing. So you know if you were missing treating an STI. The other point that I forgot to make about oral pharyngeal gonorrhea, and I'm glad you brought it up, is remember with any active untreated STI, even bacterial vaginosis, which is not technically an STI, that's left untreated, interferes with the mucosal barrier, as would gonococcal pharyngitis, which 1 out of 8 men who have sex with men have, and most have no symptoms. The pharynx will be inflamed, so they are more likely to transmit HIV. So that would be with an HSV lesion, even bacterial vaginosis. That would be with active gonorrhea. They may not know that's in their pharynx. So that goes toward the other benefit of 3-site testing, not just for PrEP and Doxy PeP, but just to know if it's there as part of our efforts to, reduce HIV transmission as well. So, and if I really have to convince someone to go in and get the definitive treatment for their pharynx, I may pull that out because it's true. I don't know if there are any other questions. I wasn't looking at the chat the whole time. I'm open to any other questions anyone has.
If anyone has questions too, they can just jump in, go off mute. A lot of people just writing fantastic presentation, Dr. Counts.
Oh, thank you. It's really an interesting medication, right? I mean, it's an old drug for a new topic. So when do we really ever get to do that? Probably not very often. So it's kind of fun that way to look at something old in a new way. Perhaps we have to do that about ourselves from time to time as well.
It's a talk that would never be sponsored by pharma. They don't make any money off of Doxy.
That's true. That's true. I will make a point. I forgot to say with regard to your question about gonorrhea, there are trials for gonococcal vaccination, which I didn't know about until I read some of these articles. I don't know how far along they are. Again, we do have the weapon, if you will, of using Bexsero for our patients that qualify by age. But if you see any caveat about concern about resistance, infectious disease doctors will always comment in these articles, we need a gonococcal vaccine, and they're in trial. So I forgot to make that point.
That's really interesting. I didn't know that. That's cool.
I didn't know that either. Like I said, I don't know how far along it's in. Who knows how much trials have been slowed down, and what country and how far that's gone.
Awesome. Leo just asked a question about, have you seen anyone that's overusing Doxy PeP?
Maybe. I mean, as much as patients will tell us, I know HIV specialists, because patients tell me, and community providers won't exceed the 60 over 90 days. So if they exceed it, number one, they'll probably get pretty nauseous. So they probably won't keep it down. And number two, then they'll run short. So there is sort of that negative feedback. Doesn't really allow for them to, they could overuse it acutely, but you don't have to give 60. That's just the max. You may decide to give a few doses and get the STI testing and talk to them about, the things we talked about from the CDC and the 3-site testing, and the fact that a lot of these other sites are asymptomatic, and we really want to know the most about your body and kind of focus it on maybe on general health, and maybe they'll start seeing it in a more global way rather than this is just a pill I'm going to pop. The other point I make is that the statistics are great, but they're not 100%. So this is not PrEP, where if you take your PrEP, we really can prevent HIV. I mean, the statistics are about 2/3, at best 80%. You saw the gonococcal statistics are about 50%. So this is not a cure. So, this is not PrEP. So I do sometimes have to bring out my little maybe firm hand. And I would, I think that was effective with that patient. And I do think there's some confusion about PrEP versus Doxy PeP and what exactly it is and what exactly we're using it for. So I don't like to belabor statistics, but I think just making that general comment was helpful for that person to not overuse it and to know they still need to be screened.
Yeah, I figured there wasn't going to be a whole lot of overuse, but I have already come across a few people I could tell were fairly promiscuous and might have a tendency to take it every day.
Yeah. I know. Oh gosh, I can't even imagine. But I had a gentleman who was
That's what
really
he
nervous.
suggested.
Yeah, who was really nervous, and he's practicing completely safe sex. And so he would qualify by patient population, but he's not practicing unprotected sex. So I said, you don't need to just pop a Doxy PeP if you're already being safe. So we had to have this discussion, I think, at 2 separate visits. So he has it in case something happens, but I just saw him actually this morning. It was timely, and he's never had to use it. So if you know they have it, you counsel them appropriately. They may not, then they may not use it when it's needed, which again gets to your point of not overusing it. Yeah.
Okay, thanks. And yes, wonderful talk.
Oh, thank you.
Thank you.
Thank you. Appreciate it. Anything else, you can always just message me in Slack. I'll do the best I can, but I presented everything I could find.
There
Well,
was
thank you very much, Dr. Collins.
Oh, no,
We
thanks so much.
appreciate it.
Okay.
there was one
Thank you,
more
very good.
question in the chat about whether or not it could be used for EPT.
For what?
EPT.
Expedited partner therapy.
Oh, expedited partner therapy. Oh, that's tricky. That's tricky. You mean in the Doxy PeP form as like an expedited partner therapy to kind of Doxy PeP them, but not really fully treat them? Is that the question?
I bet,
You mean-
I don't know, my impression is maybe it's more around like, are people sharing this? Right, if you have
Mm.
60 pills on hands, are you giving it to your partner to use
Oh,
too?
I
I bet
see.
that's happening.
I see. Yeah, I mean, that's where, saying who qualifies, who has absolutely no benefit, and understanding that maybe 3 out of 5 patient subgroups with the highest incidence of HIV that I showed you initially, 2 of those subgroups, so don't qualify for Doxy PeP. So not everybody that qualifies, and then we have to maybe get to the teratogenicity of doxycycline, right? So I guess I might have to have that discussion to see if the partner even qualifies and talk about that as well. Yeah. But yeah, probably. I mean, as with anything, right? It's true.
All right. Well, thanks again. We really appreciate it. It was wonderful. And thanks everyone for coming.
All right. Have a good day.